First, beginning with the breast. So the breasts are basically circular glands, and also they move up into what we call the tail of Spence. So the tail of Spence is a very important area, and that basically goes up into the axilla. Now the reason it's so important is because this is the most common area where breast cancer is found. When interviewing a client, you want to ask whether they have noticed any lumps or swelling in the breasts, but also asking if they've been checking these other areas, primarily focusing on that underarm area because that is where the tail of Spence continues into. Oftentimes though, women forget to palpate this area, and that is so important because that again is where most breast cancer is found. And if they forget about it, then by the time we find it, it's going to be much further along, harder to treat, and will have a worse prognosis. So we have fibrous tissue and glandular tissue. When you're looking at the breast, you're going to want to be seeing a lot of symmetry. If something abnormal is going on beneath the surface, like cancer or a lump, it's going to pull those ligaments and move that tissue, causing a pulling, puckering, indentation, or causing dimpling. We also want to look and see, do the nipples lie within the same plane? So oftentimes we're going to have females move their arms in different directions and even rotate the shoulders forward, and seeing when this happens, do the nipples move along the same plane? Or are they in different planes because of that pulling, puckering, or indentation of the fibrous tissue around it? So for fibrous tissue, those are going to be the fibers that provide support for the glandular tissue of the breasts. The fibrous tissue are often called Cooper's ligaments, or as I like to call them, Cooper's droopers, because over time those ligaments stretch and give the breast that sagging appearance. So now we have the 4 quadrants of the breast, and it's referred to kind of like the face of a clock. If you find a lump or something abnormal, you want to refer to it as 2 o'clock, 4 o'clock, based on the location. So it's sort of similar to the abdomen, but instead, remember the abdomen, we had the right lower, the right upper, the left upper, and the left lower. But because of the way the breasts are, and since there's 2 of them, a right and a left breast, then you have to refer to it as the upper inner, the upper outer, lower inner, and lower outer for each, the right and the left. So you have 4 quadrants for each individual one. And that tail of Spence that we referred to before, very important, it goes up into the axilla, and that's going to be part of the upper outer quadrant.
Now for a few practice questions. Question 1, the nurse is performing a breast exam. Which area would be most important for the nurse to assess? The upper outer quadrant, right near that axilla. And question 2, a client asks why the nurse touches the area near the armpit when conducting a breast examination. What should the nurse respond to this client? Correct answer, the upper outer quadrant of the breast extends into the axilla. Hey everyone, Nurse Mike here from SimpleNursing.com. Did you get your beautifully handcrafted study guide bundle yet? It highlights the key points and memory tricks in this video. Plus, get 900 more videos not here on YouTube, all neatly organized into playlists, along with thousands of practice questions written by actual NClex writers. So don't be scared, be prepared. Try it free today. Visit SimpleNursing.com.
Next, let's talk about developmental stages. For newborns, both genders, they're typically born with these little baby breasts. So the breast tissue can be slightly enlarged and even can secrete a white discharge, which we call witch's milk. And both of these things are because of mom's hormones being still present inside of them after birth. Even the baby girl's labia can be a little bit enlarged, but this will go away usually within a few weeks once the mom's hormones work itself out of the baby system. So next, let's talk about development as occurs in adolescence with the breast. So we have these Tanner stages. Tanner stages occur in stages 1 through 5, and it describes the development throughout puberty. We use the Tanner stages for the breast as well as female, male genitalia, including even the pubic hair changes that occur. So it goes in stages 1 through 5. For each of them, 1 is basically the boring stage. It's prepubescent, nothing's happening. So the important things to know for the Tanner stages for the breast are going to be, well, stage 1 is prepubescent, the boring stage. Stage 2 is very important though, because this is where they get breast bud development. The fancy name for this is thelarchy. So breast bud development actually begins puberty. So this is a common misconception. People often think that puberty starts with menarche, the first menstrual period, but that's not true. It actually starts 2 to 3 years prior to that during stage 2, that breast bud development. That starts puberty and starts those changes to the body. So thelarchy, breast bud development, 2 to 3 years after that, you get menarche, which is the first menstrual period, and that occurs in Tanner stage 3. So again, key point to note, it is 2 to 3 years after that breast bud development, and menarche occurs in stage 3. Stage 4 is when the breasts become in this mound on mound stage, and they start to get more of that adult-like appearance. Stage 5, for any time we're talking about Tanner stages, is always going to be that full adult stage. So it's easy to remember 1 and 5. 1, prepubescent, nothing's happening, and 5 is going to be that full adult stage. So the action really happens in 2 through 4. So important to note here in puberty, for both breast changes or changes that can occur in the chest region of both male and female clientele, is that they can have changes that are asymmetric. So the growth of the chest area and that tissue on top can be asymmetric, and there can even be some tenderness in both client populations, or in all client populations that can occur. And that is considered normal, expected with puberty, and will even itself out. So again, this is a key point often tested on. Asymmetry and tenderness can be normal and expected during puberty, and it will work itself out and eventually go away. So now let's move on to the breast, the physical exam. So just like with every other body system, inspection comes first. So with the breast, we're looking at a lot of skin. And one of the first things that we want to ask and look at is if there's a rash. If the patient comes in and they have a rash, there's a very important question that we want to ask here, is where did the rash start? If the rash started on just the generalized skin, we'd want to ask, have you been using any new detergents lately, any new lotions, soaps, any new conditioners or anything, because it could be some type of eczema or a reaction from that new product. However, if the rash started at the nipple, then we get concerned that it's something else, very much more concerning, that it might be Paget's disease, which is a sign of breast cancer. So again, if there are any rashes, you want to ask, where did it start? Did it start at the nipple, or did it start on the skin?
Now for a practice question. During a breast assessment, the nurse finds scaly lesions at the nipple with a lump behind the nipple. The nurse suspects what disease? The correct answer, Paget or Paget's disease. This is that rash or ulceration that may occur in Paget's disease.
So some key words to note and to make sure to write down about signs of Paget's disease is that rash, also any redness, scaling, or crusting. The next thing you want to do during inspection is look for any redness, swelling, heat. Now, just like anything else, this is going to be potentially a sign for infection. So especially it can be signs of mastitis, which a big population that we're going to be concerned about this is going to be our population of patients who are breastfeeding, and either whether they're breastfeeding or weaning from breastfeeding. Anytime in the body, if something gets left behind, if it's a little bit of urine gets left behind, it can cause risk for infection. So the same thing if you're breastfeeding, if a little bit of that milk gets left behind, then you can have infection that occurs. So sometimes you can get a clogged milk duct that will lead to infection as well. And so again, we're going to be assessing for signs of mastitis. And next you want to look to see, are there any prominent venous patterns? If there are prominent venous patterns that are noted on the breasts, then you want to note, is it one side or both? Remember, we like for things to be symmetrical in the body. So if it's just one side, we can get concerned because lots of times cancer can pull a lot of vascularity to it. So again, seeing any venous patterns, especially if someone has lighter skin pigmentation, then you can kind of see through and see that venous pattern, just like you can see the veins on my hand. But if it's one-sided, then we get concerned that it could be a sign of cancer and we want to investigate further. So now we're going to move on to palpation of the breast. One of the things that we're going to palpate is for texture, as well as edema, lumps, or changes that would be occurring. There are certain diseases that will cause a change in the texture of the skin. So we especially want to pay attention to if they have thickening of the skin, if it becomes leathery, thick, or if it has prominent big pores. So that's a big sign of what we call peau d'orange, which essentially means the skin of an orange.
Peau d'orange.
Peau d'orange. So it looks just like it sounds, porous like the skin of an orange. Also, we want to look for any dimpling. That's considered very abnormal, and it would be another concerning sign for breast cancer. And so, like we said before, when we're doing the breast inspection as well as palpation, we're going to want the client to be sitting, and during certain parts of the inspection, we're also going to have them sitting and asking them to perform several different movements. So raising their arms up, also leaning forward. So that way we can watch for any retraction, any dimpling that occurs while they're doing those maneuvers.
Now for a practice question. The nurse observes dimpling in adult clients' breasts. The nurse should explain to the client that dimpling of the breast may indicate a tumor. So remember, that correct answer for dimpling may indicate a tumor.
Now moving on to puckering, pulling, and indentation. If you see any puckering, pulling, or indentations, we're concerned about what's going on beneath the surface that's changing what we see and causing that pulling or that puckering. So if we were to see any type of dimpling or retraction, we as the nurse want to provide instruction to the client and have them raise their arms over their head to see if there's any further things occurring so we can assess it more. Now moving on to the nipple assessment. A big thing that is commonly tested on, so you want to write this down. Are the nipples inverted or retracted? And if they are, our primary concern is how long have they been that way? People can have different looking nipples. They can have one side be inverted, they can have both. Who cares? We really only care if it's new. If it's been like that for only like 1 to 2 weeks, then we get concerned about, again, what's going on beneath that's changing it and causing a pulling in and a changing of that nipple and causing that inversion.
Now for another practice question. During the physical examination of a client's breast, which findings should the nurse recognize as a possible indication of malignant tumor? The correct answer is retraction of the nipples. So remember, retraction of the nipples is a common or possible indication of malignant tumor.
Now we're moving on to symmetry. This is nothing new. We always look at symmetry. Especially we want to look at the nipples for symmetry and look at the lower edge of the breast. And we want them to be symmetrical, especially as they do those arm movements we talked about before. And we're worried about, with that symmetry, if the nipples do not fall within the same plane, which would occur if something's pulling, changing the ligaments so they don't move in the same direction when they're doing those arm movements. So we would have the client lean forward, as I showed before, and we would inspect the breast. This position might reveal some asymmetry that might not be visible in another position. Additionally, we want to look, is there any nipple discharge? And just like any other time when something comes out of the body, we note cacao: color, amount, consistency, odor. Is the discharge thick, thin, gray, yellow, white, bloody? Is there an odor to it? We especially get concerned if it's bloody and there hasn't been any type of manipulation or injury that's occurred. That would be a cause for concern. Although there are a few different things that can cause the nipples to have discharge that wouldn't be a concern.
Okay, now for another practice question. Which type of discharge should a nurse consider normal with palpation of the nipples during a breast examination of a non-lactating client? The correct answer here is clear. Yes, a clear discharge is a normal finding that may be obtained on manual expression from a breast, and it's frequent when stimulating that breast. So the key term there is clear discharge. Now, once again, milky discharge, blood-tinged discharge, and discharge from one of the breasts are abnormal findings in this examination. A milky discharge is normal only during pregnancy or lactation. A client with any bloody or blood-tinged discharge should be referred to the physician or HCP for further evaluation.
Now moving on to crusting around the nipple. One of the things that would be concerned is if we had crusting in that areola, because we actually have these Montgomery's glands. Those are just glands that are there to secrete a little bit of sebum or oil that helps to keep it lubricated and to keep it from having that crusting. Especially when women are breastfeeding, then that area can be very sensitive, tender, and can oftentimes have bleeding or cracking. And so the Montgomery's glands try to prevent that from occurring. Anytime anything bleeds or cracks and becomes open, then it can become at risk for infection, which can be a big concern. An additional thing that we would be assessing for would be a supernumerary nipple. If you've ever watched the TV show Friends, one of my favorites, you might remember the episode where Chandler has one of these. So a supernumerary nipple is just a fancy name for a third nipple, or more than 2 nipples. So if you think about evolution, how many nipples do dogs and cats have?
Multiple.
A lot. But that's because how many puppies or kittens are in a litter?
Oh man, so many.
A lot. Typically though, humans only have 1 to 2 babies. They can have more, but it's not as often. And so usually humans only have 2 nipples because the average amount of babies being between 1 to 2. However, sometimes they can have more. So evolutionary, there is this third nipple that has made a little appearance.
It came to say hello.
Yes. The big thing though, it doesn't really look like a nipple. So if you've ever seen one, it looks more like a mole. How do we know it's a third nipple and not just a mole? Is because there's this thing called a mammary ridge, which goes down the milk duct lines. And so that mole-looking third nipple or supernumerary nipple, think the word super just means extra. So supernumerary, extra numbers. And it's on that mammary ridge. However, this is considered normal. It doesn't lactate. It also doesn't increase their risk for breast cancer. So we just observe that it's there and note it in the chart. Now moving on to pregnant breasts. When clients get pregnant, there are some changes that you'll see to the breasts that occur because of that baby coming. And so one of the things is that the breasts will actually get large. The nipples will get large and also the areolas will darken. And there's a purpose to that. When the babies come out, remember they're not fully developed. And one thing that's not fully developed is their eyesight. They can only see contrast. So we need the nipples to be dark in comparison to the skin, so that way the babies can see that contrast so they know where to target to latch onto. Also, it is normal in pregnant breasts to have some small venous patterns in both breasts. But remember, we like it in both breasts because if it's just in one, then that could be a concern for cancer because that cancer can pull vascularity to it. Now let's talk about colostrum. Colostrum is one of the first things that come in, and it is a precursor to milk. It can come in as early as the 4th month in pregnancy. And what is that colostrum? So you might have heard about it before. It's that thick yellow, very rich in lactose, proteins, antibodies. It's actually really great for newborns because it helps them to fight off new infections and can help to boost their immune system. So the colostrum is the first thing that comes in prior to milk. Typically, milk will come in about 1 to 3 days postpartum, so after the baby is born and after the baby comes out. It can happen as early as 24 hours after the baby's born, sometimes even as late as 7 days. It just depends. One thing that can help it to come in faster after, of course, the colostrum is through, is if you latch baby, do baby to breast as much as possible, as often as every 1 to 2 hours. That will help the milk to set in faster.
Alrighty, now moving on to the men with enlarged breast tissue. So yes, it's true. Men can have enlargement of breast tissue. Now it doesn't really mean that there's a lot of fat there, but rather an enlargement of tissue. This is what's called gynecomastia. So be sure to write that one down. Gynecomastia. We see unilateral swelling, which is temporary with young men going through puberty because of that surge of hormones. We also see it with bodybuilders who take too much steroids and now add too much hormones to the body. Now, it also may reappear in aging males and may be due to testosterone deficiency. Or let's say the client is going through prostate therapy from, let's say, prostate cancer. because they're taking hormone supplements. So anytime the hormones are messed with, we can result in this gynecomastia. Even clients with liver cirrhosis can also cause this condition. So simply think about hormones primarily, and that can cause this gynecomastia. Now for a practice question. The nurse is assessing a 15-year-old male and finds soft, fatty enlargement of breast tissue. The nurse would document this as what? The correct answer is gynecomastia. Okay, now moving on to aging breasts. As you know, as we age, everything starts sagging and drooping, and really gravity works against us. So the same thing happens with the breasts. So elderly clients, their glands and tissues will atrophy or basically get harder. So as we age, glands and tissues will atrophy, get harder, or really go away. Now, a big key term is Cooper's ligaments. We call this the Cooper's droopers because breasts will lose that natural elasticity. And we get droopy breasts here. So droopy and flattened. Now, specifically after menopause, ovarian secretion of estrogen and progesterone both decrease, causing breast glandular tissues to atrophy. So on inspection, breasts look pendulous, like pendulums, right? They become flat as well as saggy. And so that's why we see decreased breast size, which makes inner structures more prominent. So for example, a breast lump may have been present for years, but once the breast starts sagging, we can see them and suddenly they're more palpable.